Fertility Center, and on behalf of Janani Institute of Fertility Training, I welcome you all to this webinar series. This webinar series consists of two topics on related to PCO.
Sebastian.
Let us start this meeting with Tamil Taiwan.
நீராறும் கடலுடுத்த நிலமடந்தை கெழியொழுகும் சீராறும் மதன வெல திகழ்பரத கண்டனிலும் அதில் சிறந்த திராவிடனல் திருநாடும் திரை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறந்தியந்து கையில் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Now I request Dr. Chitra ma'am, one of the program head of this program, to welcome the gathering and say a few words about Janani Institute of Fertility Training.
Thank you, Anandalakshmi, for that. And it's a great privilege on behalf of Janani to welcome the speaker first, Dr. Vaijayanti. We are very happy to have you here this evening to deliver a talk on PCO, which is the hot topic always for a gynecologist, because we always get to see them. And treating PCO seems very easy, but not very easy practically. All of us know that. So we are waiting to hear from you, and we are very happy that you accepted to be with us this evening. And I am very thankful to all the people who have logged in today to attend this webinar and make use of the event. Today a small gist of what is Janani. Janani is the first IVF center of Trichy. It has been functioning since 2004, and we have been always trying to upgrade it every now and then. And now the latest is we have been having stopped batch IVF since 5 years. We have had a full-time embryologist since then. So we have started doing day-to-day cases. So that gives us a lot of time to sit and discuss about the case as they come in. And then we are able to manage it better than you do it in a batch. That's one thing about it. And second thing is we have laser assisted hatching technique. And then now we have moved on to even PGT. That's the first center with such availabilities here in and around Trichy. And to say about this GIF, this is an education program that we do online since 11 months. In a row, we have been having a webinar every month since 11 months. This is mainly focused only for the peripheral doctors. They are not able to come out of their small towns and listen to all the meetings when we do it even at Trichy, and people who are in and around Trichy. So we thought we'll reach them. And all these topics are related to fertility. So we are trying to pick and choose on people who are happy to share their knowledge with us, and then help all these people to also get the maximum out of each speaker. So it's a real privilege to have this program and have speakers like Vaijayanti with us. Thank you very much for the opportunity, and I'm looking forward for Dr. Vaijayanti's talk. Thank you.
Thank you.
Thank you, ma'am. Now let us move on to the topic as such. The first topic will be covered by Dr. Vaijayanti, as Chitra ma'am introduced. Topic will be on obese versus lean PCOS, how they are different. Now let me introduce the speaker of the day. So Dr. S. Vaijayanti has completed her MD, PGO, DNB, MRCOG, and also she has completed her MSc embryology from UK. So she is an eminent fertility specialist with more than 20 years of experience in the field of fertility and has performed more than 10,000 cycles of IVF. She has worked in United Kingdom for 10 years and has obtained the prestigious fellowship in reproductive medicine and surgery at world-renowned centers of excellence in Leeds and London. She has a vast experience in all aspects of reproductive medicine and surgery and has worked with eminent figures in the field of fertility in the UK. She is the only clinician in India to have obtained MSc in embryology in order to widen her expertise in this field. She is also among the very few fertility specialists in India to have obtained subspecialty accreditation in reproductive medicine and surgery from Royal College of Obstetricians and Gynecologists in London. She returned to India in 2009 and set up the Fertility Center, which has, within a span of 10 years, earned a reputation as one of the foremost fertility centers of excellence in the country. Welcome you, ma'am.
Thank you. Thanks for that kind introduction. So can I start sharing my screen?
Yes, ma'am. Yes, ma'am.
Okay, good evening, everyone. And thank you for that kind invite, Dr. Anantalakshmi. And nice meeting you, Dr. Ramani Devi. Okay, so today my talk is on obese versus lean PCOS. PCOS is a subject which is very close to my heart since my days back in UK, while I was training at Leeds with Professor Adam Bailyn. You are all familiar with the Rotterdam criteria, and Professor Bailyn was one of the founder members who put forth the criteria. And subsequently, the international consensus criteria, the first one which came out in 2018, and the latest one in 2023, also he is one of the important members in the panel who put forth the criteria. So I was very fortunate to work with him for 3 years. Okay, so now today in my talk, I'll be discussing what proportion of women we define as lean PCOS among the PCOS population or group. And the second is what are the different phenotypes of PCOS and how does a lean PCOS fit into these phenotypes, and the clinical, hormonal, and the metabolic differences between obese and lean PCOS. And finally, when it comes to the fertility aspects, how different are lean PCOS from obese PCOS? What are the challenges which we encounter while we treat these women? Now, how do we define lean PCOS? Am I audible, Dr. Anantalakshmi? Is my screen clear?
Yeah, you are quite audible. Clear.
Okay, right. So now when we define, how do we define lean PCOS? In general, when the BMI is less than 25, then they are defined as having lean PCOS. However, when we look at a South Asian population, the BMI is 23 is when we want to define them as having lean PCOS. We all know that BMI is not an accurate predictor of body composition. The waist-hip ratio might be a better predictor of body composition, but as of now, we go by the BMI. And approximately 20 to 30% of the women with normal weight have normal weight of women with PCOS. Though we follow the Western literature, and that's the reason we are looking at these numbers. But we do know when we look at different ethnicities, this might be different, as I'll be sharing with you over the next few slides. So what are the different phenotypes of PCOS? Phenotype A is where all the three components of the Rotterdam criteria are present: anovulation, hyperandrogenism, and PCO appearance on ultrasound. When we talk about phenotype B, it is anovulation and hyperandrogenism, but no PCO morphology. Phenotype C, hyperandrogenism and PCO, but ovulatory cycles women will be having. And phenotype D, anovulation and PCO, no hyperandrogenism. It's a combination of the 2 out of the 3 for the other 3 phenotypes. So this is a study which was published very recently in 2022, coming from one of the units in Italy and one from US. So they looked into the percentage of the lean PCOS among the different phenotypes. So if you look at here, phenotype A, as we said, all 3 criteria. Phenotype B, 2 out of the 3, the rest 3 phenotypes. Phenotype C is ovulatory one, where these women are regularly ovulating, whereas the other 3 does have anovulation in it. So if you look at here, 65% of them in phenotype C were lean patients. But if you see the other groups, phenotype A, phenotype D had similar percentage, around 40% of lean patients. But when you look at phenotype B, it is very low. So this is the sort of distribution they came into when they looked into the study in their population. So this is one unit from Europe, one unit from US. So the same group then went on to show later that based on the phenotypes, when we see the metabolic profile is more, metabolic risk profile and metabolic syndrome is more linked not to the phenotypes but to the BMI. So this group went on to say that we should be actually classifying, having subtypes in each of these phenotypes. So as I mentioned before, the distribution of obese versus lean PCOS differs in different ethnicities. So if you look at Mediterranean, East Asian, and Middle East, across all phenotypes, lean PCOS is more. Lean, by defining lean, we only go by the BMI. So when we look at the Western countries, because like the US, where we derive most of our literature from Western countries, Europe and US, obese PCOS is more across all phenotypes because in general, obesity is more common in Western countries. So if you look at this phenotypes, new classification suggested according to the Italian study, which I mentioned before. So if you see here, phenotype A, the obese is 23 and lean is 31%. If you look at phenotype C, the lean is vast majority, 30% is lean. So if you look at when they have classified these phenotypes, if you look at the lean phenotype in this Mediterranean population, 30% here 30, so close to 60%. And if you look at the other phenotypes, lean also, 65% are lean PCOS in the Mediterranean region. So that is why ethnicity is very, very important when we talk about the lean or the obese PCOS. In the Western population, more of obese you will see. But based on which ethnicity you're looking at, your obese and lean will be different than the percentages you're talking about. But having said that, though the Mediterranean population have PCOS, based on the BMI we are talking about, when we look at the waist-hip ratio, that is different. Okay, so the second important aspect which I want to highlight is, we all know that Rotterdam criteria, it does mention about three factors. Three aspects, right? 2 out of the 3 criteria required to diagnose PCOS. First is oligo or anovulation. The second is hyperandrogenism, which can be clinical or biochemical. The third is presence of polycystic morphology on ultrasound. But here, if you see the last line, exclusion of other etiologies. This is very, very important. So what do we mean by exclusion of other etiologies? It's mainly, there are many conditions, many etiologies which we do exclude after doing the initial screening. But the most important of which I want to focus on late onset CH. So we cannot diagnose a patient as having PCOS unless we have really ruled out other etiologies. And it all the more applies when you have a lean PCOS woman with you, because many of these conditions can masquerade and present as lean PCOS, whereas obese also can present, but it is more applicable to a lean PCOS woman. So when you have a lean PCOS woman on hand, it's very, very important to remember that we have to rule out other etiologies like late onset congenital adrenal hyperplasia is one of those. Androgen secreting tumors, it's only these two I'll be focusing. So when we talk about late onset congenital adrenal hyperplasia, these women present with hirsutism and amenorrhea similar to PCOS women. The 17-alpha hydroxyprogesterone levels are elevated when we do it in the follicular phase. And when we do the ACTH stimulation test at 30 and 60 minutes, the levels go up by 3 to 4 times. Then that clinches the diagnosis that they may be having late onset CAH, and then we can proceed to do the genetic testing in these women. So now if you look at the diagnostic algorithm for PCOS, as we have seen, features of hyperandrogenism, ovulatory dysfunction, and ovarian PC1 ovarian morphology. Diagnosis 2 out of the 3. Suspect PCOS, exclude differential diagnosis. So these are the common conditions out of which late onset CH I mentioned. The other conditions, are mentioned here. Coming to the less common diseases, I wanted to focus on androgen secreting tumors. So when the testosterone levels are very high, this is something which we need to remember, where they can either come from the adrenal or from the ovary. So this is something to remember as an exclusion of diagnosis. Okay. Now we have seen how do we define lean PCOS and what are the differential diagnoses which we should consider. before we diagnose a patient as having lean PCOS, and it's applicable more to a lean PCOS women when we compare to your obese PCOS women, as other differential diagnosis can masquerade and present as lean PCOS. Now let us compare the symptoms between lean PCOS and obese PCOS women. This is a study which comes from one of the centers in India, specifically took this study, which is more relevant to us. So if you look at the different symptoms here, menstrual irregularity in lean PCOS compared to obese women have higher incidence of menstrual irregularities compared to lean PCOS women, p-value significant. If you look at acne, acanthosis, these are the androgens, hyperandrogenemia features, clinical features. Again, obese women have a higher incidence compared to lean women. The same thing applies here for acanthosis nigricans, and the modified Ferriman-Galway scoring also is higher when you look at obese PCOS women compared to the lean PCOS women, and you see the p-value is significant. But when you look at here, the waist-hip ratio, it is not significant. Even lean PCOS women have significant alteration in the waist-hip ratio. So that's what it shows here, and the p-value is not significant. So how do we manage lean PCOS women? We do know that obese PCOS women, when they present to us, we always talk about lifestyle intervention and diet. Does this apply to lean PCOS women? Because they're anyway within the normal BMI. So what happens is, even with lean PCOS women, when they lose weight, they have to maintain their weight, but they can also afford to lose a little bit if it allows them to. Say with a BMI of 23, you can still encourage them to lose another, to bring down the BMI to 20, in which case the symptoms can get better. So this is just to show that PCOS women, when they have symptoms, when they lose weight, the symptoms get better, and when they put on weight, the symptoms get worse. So this applies also to lean PCOS women, definitely applies to obese women, but it also applies to lean PCOS women. So it's important is maintaining the weight, and if possible to lose a little bit more. So now when we come to the nutritional management, again, as we have seen with the obese PCOS women, it's very, very important for them to maintain a balanced diet with lots of fruits and vegetables to include the micronutrients. That's what we are looking at here. Because when they take a diet which is very well balanced with lots of fibers, vegetables and fruits with the proportionate, of cereals and the pulses. When they do that, if you see there is an improvement in the lipid profile, there is an improvement in the inflammatory markers and the hormonal glucose metabolism features also. So as in obese PCOS women, nutritional management is important. It is equally important in the lean PCOS to maintain their weight. So when we look at the management algorithm for lean PCOS, lifestyle modification, weight maintenance or avoidance of weight gain is the most important thing. Avoidance of any more weight gain is going to push them into the phenotype, it's going to push them into, even if they ever had ovulatory cycles, when lean PCOS women, if they are going to gain weight, even 1 to 2 kg, they will move towards having overweight or obese PCOS. So avoidance of weight gain is most important. That is maintaining their weight, or if possible, to lose the weight to a little extent. Okay, through dietary modifications, consumption of ample amount of vegetables, fruits, vitamin D, calcium, and herbs. So if there's an inadequate clinical response with these dietary modifications, then you can consider adding metformin with or without myoinositol, because we don't have a strong evidence set to use myoinositol, but metformin we can use. So when it comes to the specific symptomatic management in lean PCOS women, we follow the same as what we do for an obese PCOS. So hirsutism, combination of mechanical and pharmacological, oral combined contraceptive pill or androgen receptor blockers. So when we look at menstrual dysfunction, again, it's progesterone alone or combined pill. And again, acne, both topical applications, and when it comes to infertility, I'll be elaborating later, so I'll be leaving it now. So similar to what we do with obese PCOS, we'll be managing the symptomatic management, but the severity is less in lean PCOS compared to obese PCOS. Now, when we move to the hormonal profile, how are they different between lean PCOS and obese PCOS? In general, lean PCOS women have high LH and testosterone. So if you look at the chart coming from the same group here, I just want you to focus on the total testosterone levels here. So if you see here, lean PCOS women and obese, the hyperandrogenemia is more with obese PCOS women as compared to lean PCOS women, and the p-value is significant. So hormonal wise also, lean PCOS women are better than obese PCOS women, but they still have hyperandrogenemia compared to the weight-based weight-matched controls. Okay. Now we have seen clinical symptoms. Second, we have seen hormones. Third, we are moving on to the metabolic parameters. Both obese and lean women compared to control group are metabolically worse and have more visceral adiposity. And that is the reason the waist-hip ratio is altered even in lean PCOS women, which I showed you before. So lean PCOS women have metabolic risk, which is similar to obese PCOS, but at a lesser intensity. This is how it works. Obese PCOS women have higher metabolic risk. Lean PCOS are lesser than that. And when we compare with weight-matched controls, lean PCOS are better or worse compared to their weight-matched controls. That's how it works. So they also have metabolic risk, but less compared to the obese PCOS women. So now when we look at these metabolic parameters between lean and obese, if you see here, fasting plan, these are all glucose measurements of glucose metabolism. But according to the recent guidelines, and we have always done that, GTT is a better marker to assess the hyperinsulinemia, not the glucose metabolism parameters is what is put here. But if you see here, the parameters are worse with obese women as compared to lean women. And when we look at the hyperlipidemia parameters, serum triglyceride, serum HDL, again, these women, it is worse in obese PCOS women compared to the lean PCOS women. So when it comes to the metabolic parameters, as we have seen, obese women fare far worse than lean PCOS women. Lean PCOS women fare less than what we see for a weight-matched controls. So type 2 diabetes and impaired glucose tolerance higher in obese than lean PCOS women. Lean PCOS men are more hyperinsulinemic than weight-matched controls. When we look at lipid profile, LDL and total cholesterol is elevated in lean PCOS compared to controls. And this is to do with the cardiovascular risks. So now we move on to the subfertility issues. We have seen the clinical parameters, the hormonal parameters, the metabolic parameters. Now we move to the subfertility issues. So when we talk about ovulation induction in PCOS women, the first line, the oral agents like clomiphene and letrozole have been in use for a long time. Clomiphene for more than 5 decades and letrozole since the early 2000s. And according to the current available evidence, we can say that letrozole should be considered as first-line agent, particularly in PCOS women, as several studies now have proven efficacy far better than clomiphene citrate. And also when women are resistant to clomiphene citrate, if that is the medication you have used for them as a first-line agent, you can still try to use letrozole if they are resistant to clomiphene with the increasing doses. So, but what lean PCOS women, when we look at what is the difference is, they are very, very sensitive to ovulation induction agents. So even if you start off with a 50 milligram clomiphene citrate, that can be a bit too much for some of the lean PCOS women where you have to use lower doses. So when we are talking about up to 2 follicles is okay, particularly when you do OI or ovulation induction, we don't want too many follicles. We are looking at monofollicular growth, monofollicles, or single follicle is what we are looking at. Otherwise, they have a higher instance of twin or multiple pregnancy. So here we are not just looking at 2 follicles here, more than that, because their ovaries are very sensitive, and that is something we have to take into consideration. And metformin can be used as either as a primary agent also or as an adjunct. When we say metformin as a primary OI agent, how does that apply? There are studies which have shown that when women are put on metformin, some of them, along with the lifestyle intervention, their cycles do become regular. So, but the number of ovulations you get when you use metformin as a primary agent, as opposed to using direct ovulation induction agents, gives lesser ovulations when you use metformin. So it would be prudent to start them off with ovulation induction with the oral agents. But for some of them, when you have that initial weight loss they are trying, you can still use, and if the pregnancy is not an immediate then you can still consider using metformin in the initial phase and then add on oral agents at a later date. So now when we talk about resistance, clomiphene resistance, as I have mentioned before, letrozole can still be used when you find a woman who has clomiphene citrate resistant, and it still works in close to 10 to 15% of the women still ovulate when you put them on letrozole when they have not ovulated with clomid. But how do we define clomid resistance or clomiphene resistance? We are going to start off with a 50 milligram dose. And if they don't respond, you're going to put it to 100 milligram. If that doesn't respond, you're going to put it up to 150 milligram. Beyond 150 milligram, though you can go up, what happens is the anti-estrogenic effects become more significant. So it would be prudent to stop at 150 as it gives a good balance between increasing the dose and the anti-estrogenic side effects. So that is what we define as clomiphene resistant when a woman does not respond to 150 milligram of clomid. So the second line agents you would use in these circumstances would be gonadotropins and laparoscopic ovarian diathermy. When we talk about LOD, a thin woman with high LH who has not responded to the oral agent is the only indication for laparoscopic ovarian diathermy. For obese women, LOD does not help. So there is no point in doing, just because we have done a laparoscopy and you see a possible polycystic ovary, one should not be going and drilling the ovaries, because as fertility specialists, we always see the other end of the spectrum, people getting into poor ovarian reserve and premature ovarian failure. So unnecessarily ovaries should not be drilled, and in obese women, drilling will not help. So the only group of patients for whom laparoscopic ovarian diathermy as an indication is a thin PCOS woman who has a high LH and who has not responded to your oral OI agents. This is the only group of patients for whom you are going to offer laparoscopic ovarian diathermy. So when we talk about letrozole resistance, with clomiphene resistance, it's very clear. You're going to use increasing doses. 150 doesn't work. You can define them as having clomiphene resistance. But when we talk about letrozole resistance, there is different definition when we look at the literature. Some of them consider 2.5 milligram given for 5 days don't respond, letrozole resistant. For some others it is 5 milligram or 7.5 milligram. So this is a little bit vaguely defined, but we can consider that as we do with clomid, we can go with increasing doses, and when they do not respond to 7.5 milligram, we can consider them as having letrozole resistance. So this is an algorithm which comes from the International Consensus Guideline 2018. So regarding fertility treatment, so if you see here, the first line intervention is always lifestyle intervention. Then we are going to go with the specific OI agents. So if you see here, letrozole should be considered as the first line agent. Clomiphene citrate can also be used, because in many countries, letrozole is not licensed for use for fertility. So in those countries, they still use clomiphene citrate. Clomiphene citrate, you can add metformin to clomiphene citrate, and metformin as on its own can also be used, as I said, though the number of ovulations you get when you use metformin is far less as when you compare these two agents. And the last is gonadotropins. Again, these women who gonadotropins, though here is given under the first line, this is a very, very small group of patients for whom we want to use gonadotropins, because in a PCOS women, particularly a thin PCOS, gonadotropins, they can be very explicitly sensitive to gonadotropins, and that's not what we want to use. Okay, now moving on to the second line agents. As I said, gonadotropins is the second line agent, and LOD, I have told you for whom it is indicated. Thin women, high LH, who are not responded to the oral agents. These three should be there for you to offer laparoscopic ovarian diathermy. So this is how it goes, the OI in PCOS women. Okay. So when we talk about gonadotropins, which are second line agents, lean PCOS women are very sensitive. So how do we do the increments in these women? Usually when we use gonadotropins, we start off with, say, particularly for a thin PCOS, something like 50 as opposed to, say, 75 for an obese PCOS you might consider. So when you increase the dose, we use increments of, say, if it is 75, 37.5. Whereas with the lean PCOS women, you have to be very, very careful. 25 would be a better increment, or sometimes 12.52. So you have to be very, very careful. Otherwise, you will come up with many, many follicles. We are not looking at just 2 follicles or 3. We are looking at a higher order multiple pregnancy if you have many, many follicles, particularly in an OI setting or an IUI setting, which you're going to use. Here, what is important is, as ART specialists these days, we do what is called segmented ART, segmented IVF, where particularly in the PCOS women, we are going to do stimulation, collect the eggs, make the embryos, freeze them. You're going to put it back in a cold cycle the next month. So that is called segmented ART. By doing this, we have almost eliminated OHSs from the dictionary of the ART specialists in the IVF setting. But we still see OHSs. Where are these coming from? They're coming from OI and IUI pregnancies, particularly in PCOS women. So there is no role for segmented ART in a woman who is normal, who is having a normal reserve or a poor reserve. The only indication where segmented ART has got a role, evidence-based role, is in women with PCOS. So that is important to remember. So we cannot be pushing women into OHSs. We have to be very, very careful in how we are going to do the dose increment in lean PCOS women. When we talk about multiple pregnancy, so as I have said, we are not talking about twin pregnancy here. We are talking about triplets and higher order multiples like quadruplets. Here there is a lot of it involves a lot of maternal and perinatal morbidity and mortality. So we have to be very careful. Any follicle more than 14 mm is capable of giving a mature egg. So intermediate size follicles also should be taken into consideration. And if you are more than 14 and above, you have to cancel the cycle. Otherwise, you might end up with a higher order multiple pregnancy. So is it within, when we do gonadotropins for OI, is it within the realm of gynecologists? I don't think so, because they need to be referred to ART specialists, mainly because the way the increment is done, the way the close monitoring has to be done, it is not within the realm of gynecologists. It's mainly the oral agents they can use, and if it doesn't work, then it mandates that they refer to an ART specialist where the monitoring happens with the gonadotropins, particularly in the lean PCOS women. Okay, now let us talk about the newer protocols. I call it the newer protocols. So normally what happens is, in a traditional protocol, say if you look at clomiphene citrate or letrozole, how do we increase the doses? Particularly when the PCOS women are anovulatory, which means they do not have regular cycles, we are going to give a progesterone withdrawal bleed. And then we are going to start the dose, say 50 milligram. And you're given for 5 days, you're done your follicular study, a week later, there is no response. So you're going to either wait for another spontaneous bleed, or you're going to give your progesterones for withdrawal bleed, then put the dose up to 100 milligram. That is the traditional protocol. So again, if that doesn't respond, the same story starts again. So by the time you're going to reach an ovulatory dose, particularly if a woman has got as a response to 150 milligram, it might take 3 to 4 months. So here we are looking at 3 to 4 months. Whereas by what happens during this time is the patient loses the compliance. They may not come back to you because they are fed up, they are frustrated. And we know that there is a very high dropout rate. Even in IUI cycles, if you see, there are lots of data stating the dropout rate. I don't have my slide here, but there is a huge dropout rate after every cycle of IUI. Though you would have counseled them extensively, the dropout rate is huge after every cycle of IUI. They go to your next door neighbor, or they may stop treatment because it's psychologically quite, it is quite difficult for them to take it on board. And they may come to the conclusion that they'll never conceive. Many of the PCOS women who come to us already do, but they go to many clinics before reaching out to us, and many of them are quite depressed when they come to us, stating that I have got PCOS, I will never be able to conceive, and that is the mental this thing they get into. So what happens is, when we look at some of these newer protocols, it reduces the time to ovulation, and that's what I would want to present to you. So there are two types of protocols you can use. One is stair-step and second is extended protocol. So what is stair-step protocol? As I said, start with 50 milligram for 5 days. You're done your follicular study. There is no response, no need for withdrawal bleeding. Put it up to 100 milligrams straight away. And if there is no response, put it up to 150 milligrams straight away. That is called the stair-step protocol. So this is the review article published in 2020 looking into the stair-step protocol in relation to clomiphene. If you see here, there are 4 studies, 2 are retrospective studies and 2 are randomized control trials. So if you look at the time to ovulation in the stair-step protocol, the duration is almost half or 1/3 to what you would get with a traditional protocol. So the compliance will be better. So and if you look at the ovulation rate also, when you look at a stair-step protocol, a particular dose, which is 150 milligram, works well in this protocol as compared to what you see with a traditional protocol. So that is what you see here in these charts. So now coming to the stair-step protocol, letrozole, similar story, start with 2.5 milligram. If it doesn't work, no need for withdrawal bleeding, put it up to 5 milligram, put it up to 7.5 milligram. So now we move on to the extended protocol. What is extended protocol? If there is no response for 5 days of, say, 100 milligram, you're going to keep the same dose for another 5 days instead of putting it up. So that is the extended protocol without any withdrawal bleeding in between. Extended protocol, letrozole, same. So if you started for 2.5 milligram, if there is no response, you just extend the dose rather than putting it up. So this is a publication which was published again quite recently, 2022, looking into the extended protocol. So if you see here they have defined letrozole resistance as 5 milligram of letrozole given, no response. That is letrozole resistant. Here close to 70 women who have failed to ovulate were put through the extended protocol somewhere between 7 to 10 days. And if you see here, vast majority of them responded when they extended the protocol, leaving only 5 out of 70 who had not responded. And we also have been doing this for a long time now, for the close to 6-7 years, and we also have found similar results. So advantages: shorter time to achieve follicular growth, efficacy is better, more patient compliance, and it is more cost effective. So newer protocols are data. So just to set the stage, we are a tertiary referral center. We hardly have any treatment naive patients walking into a clinic, which means we have never had any OI coming into a clinic. Primarily, it is very hard and very few. Say in a year, I would get 3 or 4. That's about it. So most of the patients who come to us, 95% of them have tried, tested elsewhere, either 1 cycle, 2 cycles, many cycles, gone to many gynecologists before they reach out to us. So we have a very highly resistant population reaching out to us for either OI or IUI. So this is our IUI data. So we take more of a pragmatic approach. It's only for the irregular cycles, which means PCOS women who went through IUI. So if you look at here, we put 5 milligram of Clomid and about 70% responded. But when we use the extended protocol, a significantly more number of women responded, leaving very few women who are non-responsive. So we have been using it for the past few years and we have found brilliant results. Okay, so when we move on to IVF, when obese versus lean PCOS, when in IVF, pregnancy rates are better in lean compared to obese PCOS, according to some of the studies, though these numbers are quite less and we still need more data on it. And because of, as I have mentioned before, lean PCOS, even in obese PCOS, sometimes you have to do segmented IVF if the response is on the higher side. But for lean PCOS is all the more relevant because they're very sensitive ovaries. Risk of OHSS is there. So segmented IVF is the way forward. And low dose, even as low as 100 units, you might have to start, particularly if you have a thin PCOS women on hand when it comes to IVF. Even 125 sometimes more for these women. And careful monitoring is needed to avoid OHSS in these women and keeping them in the good health. Okay, so now to conclude, there are several limitations of the studies, what we see in literature when we want to specifically look into lean PCOS, and majority of these studies have low to moderate quality evidence. The evidence is not robust. Then many of the study, why it is not robust? Because many of them don't even follow the Rotterdam criteria. And these are all small sample cohorts. And studies on certain ethnicities can't be generalized. Say, for instance, a Western population cannot be generalized onto the rest of the world. So we need our own statistics, our own data from our own population if we want to, if we want to work closely with these women. So, and in adolescence, the diagnosis can be quite challenging, though the recent international guidelines has addressed that beautifully. So now large, carefully structured RCT is the need of the day. And hopefully with this, we'll be able to have the specific data relevant to that particular population we are talking about. Okay, in this context, I would like to invite you all for a conference we are having on the 24th of March, Metabolic Syndrome in PCOS, an update. Okay, thank you. And I'm welcome to take any questions if you have. Thank you.
Thank you so much, ma'am, for a very wonderful presentation on obese versus lean PCO. Now I request the delegates to post their questions in that
and the chat box, so
yes,
that we'll be able to
yes,
ask. When you use these extended protocol regimes, do you think that they have multiple follicles or they just have only one?
They have only one or sometimes 2, but that's okay. Yeah.
Even clomiphene?
Sorry, even with?
Clomiphene?
Clomiphene I don't use. I use only letrozole.
Okay. So you also use the step-up protocol of day 1 starting with 2.5, second day 5 milligram.
No.
Huh?
No.
Because that also sometimes gives good results. But we also find that extended letrozole regime is safer, and as you say, it produces 1 or 2 follicles.
But the incremental dose, there are multiple follicles.
Yes.
And you give 2.55, 7.5.
Yes.
So then in the ART contest, what will be the quality of eggs? Do you have any difference in the quality of egg oocytes between obese and lean?
Yeah, see, the concept of having poor quality oocytes in PCOS, there is no evidence at all. We don't find any difference. Our PCOS women have as brilliant results as our normal, reserve women. So we don't. That's no difference as far as I'm aware of.
Okay. Do you go for lifestyle modification? You ask the patient to wait for 1 or 2 months prior to taking up for ART.
1 to 2 months. I mean, with regards to lifestyle intervention, they should be having it as the first step, even before we do anything, particularly from the community. The gynecologist is where they take themselves to first, not the ART specialist, right? So right from that point, it should start. By the time they reach a tertiary center like us, they have already gone through the run of the mill again. Okay, they were right. They have had OI, they have had IUI, they have had 7 years and 10 years of infertility when they reach your door. Anyway, that's how it works for us mostly. I'm sure it's done doing the same for you too. So when that is the case, I don't see a major, sort of this going to lose weight for 2 months. It has not happened for 10 years. Is it going to happen in 2 months?
Yeah, we have to accept and then we have to go ahead. Yeah.
True. Yeah. So, but that is more applicable in the community where the patient takes themselves first to the gynecologist, so that at that point, lifestyle intervention is the first intervention to happen. Then, OI. They should be given a time limit, like 3 months, 6 months, lose 5 kilos and come back. It should be result oriented. You have to tell them like 5 kilos is what I want to see you reduced in 3 months. So when we encourage them with psychological support and all that, they'll be able to achieve that. We have to give them that numbers to work on. If we just say, go and lose weight and come, they are lost. So we have to tell them what is the weight we are looking at. And studies have shown even if 5% of the weight loss is going to immensely reduce your waist-hip ratio, and it converts into good responses with ovulation induction agent. So that's what we should be aiming.
What is the percentage of lean PCOS do you see in your ART practice? Because for me and Chitra, I think almost we very hardly see lean PCOS patients. Hardly see.
Yeah, so I have not looked into the phenotypes of the PCOS women we do. Yes, we have lean PCOS women, but I would not be able to put a number to it. So probably I would say 1 in 3 is what I would say, but not more than that. Yeah.
Okay. Anyway, one thing that you have stressed upon doing LOD only for lean PCOS, not responding to medication. Because we see a lot, and more than that, specifically you have mentioned either unilateral also.
Unilateral is
also good, because we sometimes see patients coming with one drilling at one doctor, having one pregnancy, again going for another drilling for when she plans for the second, and ultimately she lands up with a premature ovarian failure. So with obese PCOS, we have to be very careful. Better it is not, you tell the patient that it is not going to give better results when you are going to go for LOD.
Yes, true. Yeah.
Chitra?
Yes.
And about the metabolic syndrome also, we have to be very careful before taking these patients for ART, especially obese patients with a higher BMI and at the extremes of say beyond 35. I think it is very much essential to have a complete evaluation of the cardiac status and the lipid profile. Metabolic status should be assessed, and the chances of hyperglycemia is going to be very high. Isn't it? So all those things have to be controlled, because that is going to have an impact upon the pregnancy as subsequent pregnancy also.
So GTT is something which we have to do. That is primarily when they come to us in the beginning, we have to do, correct it, only then put through fertility treatment. That is the right thing to do, because
hemoglobin A1C should be minimally less than 6.5 to plan.
1 in 5 will be frankly diabetic. And HbA1c has to be controlled, and only then put through fertility treatment. Yes.
Then how often do you find metabolic syndrome in adolescent girls with PCOS? This is something not related to lean. But
you see, I practice only fertility.
Okay.
I don't see gynecology, so we don't see adolescent PCOS women.
But I think 1/3 of the patients with adolescent PCOS, they do have metabolic syndrome. And
so we have got a couple of talks in our conference coming up also with adolescent PCOS, which the pediatricians also will be addressing. Childhood and pediatric, under obesity.
Because childhood obesity is increasing, all this will obviously have an impact.
Yes.
Actually, one biochemist, she did her PhD in adolescent PCOS, and her incidence of metabolic syndrome was almost 30%. And again, frank diabetes was seen in 5% of the cases. Less than 19 years. It was so sad.
Very sad. Very sad. Yes.
Very sad.
Very sad state of affairs. Less than 19 if you have diabetes. You have a long way to go. Yes, true. Yeah. Anything else?
I have a doubt now.
Yeah.
If we have a patient, as you said, a lean PCO with high LH and resistant to oral oocytes.
Yes.
Without planning for laparoscopic ovarian drilling, if we plan for IVF and that too fail, will oocyte retrieval will act on the same way as laparoscopic ovarian drilling? Can we take it in the same way, or we should proceed with another laparoscopy?
Yeah, but why should you do IVF when someone has got, you still haven't used gonadotropins, you still haven't done IUI, you have skipped the.
We have tried everything. ma'am.
Finished.
You have
All
tried
this is
everything, then
Yes.
you can go for IVF.
With low dose gonadotropin, she will not respond. So just when we increase, we will get
In
multifollicular.
that case, you do drilling, then you offer OI. That would be the right thing to do. See, if you have not done drilling, when they have a thin PCOS, high LH not responding, you do your LOD and then try again. That would be the first approach before you take them up for IVF.
Yeah, but Anandi's
My
question is whether doing
oocyte retrieval will have the same
LOD.
No, we are not looking at it in the same viewpoint. No,
Okay.
we are not. No.
Okay. Thank
Okay.
you.
Yeah. Okay. Thank you. Yeah. Okay. Anything else?
Thank you. Thank you.
No, thank you so much for the opportunity,
Thank you,
Dr. Ramani Devi, Dr. Chitra, and Dr. Anantalakshmi, and have a great rest of the evening with your fellows. Is it? I don't know, doctors from the periphery. You said,
Yes.
yeah. Thank you, and hopefully we'll see you all soon. Yeah. Thank you. Thank you so much.
Very
Yeah.
much. Thank you. Thank you very much for being with us.
So let us proceed with the second talk of this evening, which will be on pregnancy following PCOS. So this talk will be delivered by our own program head, Dr. Ramani Devi ma'am.
Good evening, everybody.
Yes, ma'am.
It is a pleasure. What, Anandi?
Ma'am, CV ma'am.
See, it is for our own gift
Okay.
members.
Okay, ma'am. I think no need for any introduction, so you can proceed. How to manage pregnancy following PCOS?
So long, we were listening to Dr. Vaijayanti, how to make a PCO woman become pregnant. So are we happy once if the woman becomes pregnant? No, not at all. She becomes a very high-risk candidate during the pregnancy. So now my talk will be directed under the following headings: introduction, incidence and prevalence, why pregnancy incidence has increased in PCOS, what is the impact of PCOS upon pregnancy, that is maternal and fetal, and pregnancy upon PCOS, what are the complications we can anticipate during pregnancy, how to manage, and do we need to give metformin and myoinositol? What are the future risks both for the mother and the fetus, and the conclusion. So we know these two great people are Steen and Leventhal, who first described the polycystic ovarian disease. Introduction, I think I can skip because Dr. Vaijayanti has already enumerated this. And the incidence and the prevalence is 2 to 8% of incidence among the reproductive age group. And it is the most common endocrine disorder among the women of reproductive age group. Has ethnic and regional variation, highlighting the lifestyle. This is what she has also mentioned. We have higher number of polycystic ovarian disease patients in the Western country when compared to the Eastern population because of their increasing BMI. In India also, among adolescents, 9% incidence, and among the reproductive age group, it is around 6.5%. And again, I would say there will be a regional variation, and sometimes we do come across up to the incidence of 20%. So what are the clinical manifestations? It starts right from pubertal, and the cutaneous manifestations, reproductive problems like amenorrhea, oligomenorrhea, infertility, early pregnancy loss, and metabolic problems are very high in polycystic ovarian disease. The clinical manifestations are, it can lead to anovulation. As a metabolic component, the patient can have diabetes, insulin resistance. It will aggravate atherosclerosis, hirsutism, hypertension, and early onset endometrial carcinoma is also seen in polycystic ovarian disease. So the diagnostic criteria, I think this slide again I can skip because she has beautifully explained the varying phenotypes, phenotypes A, B, C, and D. So this is the same one. Phenotype A is anovulation, hyperandrogenism, PCO. Type B is oligoovulation with hyperandrogenism. Type C is hyperandrogenism with PCO morphology. And type D is oligoovulation with polycystic ovarian disease. Now let us come to the infertility part of it, which she has beautifully explained. And as a result, it causes the patient lands up with the pregnancy. Then polycystic ovarian syndrome causes more than 75% of the anovulatory infertility. Fertility has improved because of all the drugs that are used for anovulation and the advent of ART. And now we see more and more of patients who are becoming pregnant following treatment with polycystic ovaries. So this has definitely increased, as she has mentioned very well, that lifestyle modification is essential, and this should be done earlier before referring to the patient consultant with, for ART, and it should be at the primary community level. She has to be educated. So this is what is being done. Even a slight weight loss. See, 6.3 weight loss, the outcome is 12 out of the 13 patients recruited in this group had ovulation, and 11 out of 13 had become pregnant. Again, reduction in 5.6 according to Hallman study. He says that 80% has an ovulation rate and almost 30% of pregnancy. Then these are all the other varying studies where they reflect the same thing. So the weight loss around 5 to 10% over a period of 6 months is going to increase the pregnancy rate by 50%. So just a repeat of medical therapy, clomiphene, letrozole. I think now letrozole should come first, then gonadotropin, and then IUI ART. And as adjuvant, we can use metformin and myoinositol. Though for myoinositol, there are only few documented studies. So here, in order to avoid the ovarian hyperstimulation syndrome, in vitro maturation is coming into vogue. Then, first of all, before going in for a planned pregnancy through IUI or ART, there are certain things. Preconceptional care is very, very important, because if you concentrate on this, it is going to significantly reduce the complication. First thing is lifestyle modification, optimizing the pre-pregnancy weight, supplementation with folic acid, and I think I should add up vitamin D also, because that is a major drug which helps in correction of this policy in as an adjuvant in PCOS patient. Control glycemic profile to less than hemoglobin A1C of 6.5. Assessment of current medications and its teratogenicity should be monitored and changed. For example, if a patient with PCOS in the third decade, she is likely to have associated hypertension, and if she is already been put on ACE or ARB inhibitors, that has to be changed. So these are some of the small things which has to be taken care, like cardiac evaluation and the all the other lipid profile, everything should be monitored, and immunization state should be monitored, and booster dose should be given whenever is necessary. So this is according to the National Academy of Medicine, Institute of Medicine. This is the recommendation for a healthy, what should be the increase in the weight gain during pregnancy. For example, if the patient is a lean PCOS, the total weight gain can be 12 to 18. And as she increases, when the obesity, when the BMI is more than 30, her weight gain should be only 5 to 9 kilograms throughout the entire pregnancy. For a normal weight patient, I would say it should be only 11 to 12 kilos, and overweight, it should be on the lower side. So what are the risks of PCOS upon pregnancy? PCOS can have an impact upon the early pregnancy, as in the form of pregnancy loss. Patient can present with gestational diabetes, then pregnancy-induced hypertension and preeclampsia, and birth weight of the baby can be either low or high. Generally, we have a macrosomic baby. If the patients have an altered altered glucose glycemic status, and it can be low if there is associated vascular involvement. They can have multiple pregnancy. There is increased induction of labor in these women, and increased operative delivery and LSES. There is increased maternal and perinatal morbidity and mortality in women who are having polycystic ovarian disease. So then there was a population-based cohort study that was done regarding the risk of adverse pregnancy effect, where they have seen obese patients and those who are using ART, the risk is 60 versus 34.8 in compared to obese versus non-obese. And in ART patients, the risk is going to be 13.7% versus non-ART conceptions 1.5. And the incidence of preeclampsia is raises to adjusted odds ratio of more than 1.5, and preterm birth is also very common, and gestational diabetes incidence is double, and large for gestational age, it is around 1.39 to 1.19 to 1.69, and increased risk of meconium aspiration, and the chances of having a low Apgar score less than 7 at 5 minutes is common. So in conclusion, women with polycystic ovarian syndrome are the increased risk of adverse effects of pregnancy and birth outcomes that cannot be explained only by ART. Even a patient who has conceived with ovulation induction or with IUI, they have the same risk. So then this is another clinical study where they have the risk of gestational diabetes and pregnancy-induced hypertension are increased. So there is a similar, this was a study from from China, where they have found out that there is a higher incidence of PIH and gestational diabetes. Now coming to polycystic ovarian disease and early pregnancy loss. So with all the difficulties, the patient undergoes ovulation induction with IUI or ART, but somehow the chances of early pregnancy loss is found to be higher. So the prevalence may be up to 30 to 50%. This is pathophysiology is basically related to obese, hyperinsulinemia, hyperandrogenemia, abnormal pituitary gonadotrophin profile with elevated LH. And there may be endometrial dysfunction. BMI excess is associated with increased risk of undergoing this early pregnancy loss. So the pathogenesis is individually hyperandrogenism can cause insulin resistant obesity. We all know that obese women, they have a higher incidence of early pregnancy loss, and there is increased fibrinolysis and endometrial dysfunction or endometritis can happen in polycystic ovarian disease, that because there is alteration in the uterine microbiome in PCOS. So that has to be corrected. So 3 times higher risk, 30 to 50% in PCOS versus 10 to 15% in the control group. This was a CLUX study, and obesity and hyperinsulinemia are independent risk factors, and the mechanism that is unclear, that is the implantation mechanism. Glycolidin, there is alteration of the glycolidin, IGF-BP, and plasminogen activator activity inhibitor, all may have been associated risk factors. Few studies showed that metformin decreases the risk of early pregnancy loss. That was a major work done by Gluck et al. So hyperandrogenism, what is a mechanism? Abnormal secretory endometrium, because there is alteration of the endometrial pattern and hence suboptimal milieu for implantation. Sometimes the patient gets aborted even before she understood that she has become pregnant. Then again, reduced expression of endometrial protein that will correlate well with the luteal phase dysfunction, detrimental effect on the oocyte quality. This can happen because of hyperandrogenemia. Elevated LH. Persistent rapid pulsatile secretion at an exaggerated amplitude. It can lead to premature maturation, aging of oocytes, and dysfunctional endometrial development. So these are all the causes for early pregnancy loss. Then how we can overcome this is, to some extent, they have proved that metformin is supposed to reduce the incidence of early pregnancy loss. Next, coming to the polycystic ovarian disease and gestational diabetes. Now we need to know when should the patient be screened for gestational diabetes. This is one according to the ADA criteria. See, we were using 75 grams of OCGCT. But now the DIPSI criteria, they have made it very clear that oral GCT is alone enough. There is no need for GTT. That is a single assay of blood glucose level after intake of 75 grams of oral glucose. 2 hours later, you do a single test. So that is irrespective of the prior meal. That is the GCT, and that is being approved by DIPSI. So when you should do it, ideally, it should be done in the first trimester, then repeated over the second trimester, 24 to 28 weeks, and once again in the early third trimester. So again, now there is categorization of glucose intolerance during pregnancy, and now Dr. Seshaya group has come down with the early predictive marker and detection when to do the GCT. So now they are doing for diagnosis of GDM, 2 hours postprandial blood glucose. If it is more than 140, then it is classified as GDM, and they have a higher chance of developing type 2 diabetes in future. Then again, CGA, that is isolated glucose intolerance, that is between 120 milligram 2 hour post glucose sugar, postprandial sugar, if it is 120 to 140, then also they found out the adverse pregnancy outcome was similar to this GDM. So it is only even an isolated glucose intolerance, it has got an adverse effect similar to that of a frank GDM. That we have to understand. Then comes the early gestational glucose intolerance. That is the newer one, that it should be tested, not 13th week, it should be done at the 10th week. So what they claim is, you do a postprandial blood sugar. See, it should be less than 110 grams per deciliter. These people are prone to develop GDM in future. So another thing is, they have given an idea, like if the patient is found to have a postprandial sugar of more than 110 grams per deciliter, then the chances of developing future diabetes for not only for the mother but also for the baby is high, because the baby starts producing insulin level when the maternal glucose level is found to be more than 110 or 120 at 10 weeks of gestation, because the baby starts producing insulin at 10 to 12 weeks of gestation. So if we are able to correct or maintain the blood glucose level less than 120, then it is always better, than we can avoid the development of future development of diabetes for the fetus also. So this is a demographic profile and clinical characteristics of various pregnancies where they have found out the incidence of diabetes is found to be, gestational diabetes is found to be higher with PCOS patients. So the incidence of GDM is around 40% in PCOS versus 4% in control group. Insulin resistance created by changes in diabetogenic hormones like HPL, estrogen, and progesterone, as well as baseline insulin resistance, is a characteristic feature of PCOS. And risk of GDM is independent of obesity. See, that was previous study also in lean PCOS. Also, they are also likely to develop gestational diabetes. And metformin appears to reduce the occurrence of GDM. So let me go back to the previous slide. So when you find that at 10 weeks of gestation, if the postprandial blood glucose level is found to be more than 110 milligrams percentage, then according to Dr. Seshi and group, they are now insisting that the patient can be started on metformin so that they have a control of their blood sugars at an earlier phase, which will prevent the onset of hyperinsulinemia for the fetus. So what are the GDM complications? Once when the patient develops GDM, the fetal macrosomia can happen, polyhydramnias, instrumental vaginal delivery, LSCS, birth trauma, high perinatal morbidity and mortality. And again, you see this 40% will develop type 2 diabetes during the reproductive age group. That is, by the end of 5 years, the women with gestational diabetes are at a high risk of developing type 2 diabetes. Then next comes the polycystic ovarian disease and pregnancy-induced hypertension. This hypertensive disorders or preeclampsia accounts to 15% of the maternal death, and it is found in 6 to 8% of all pregnancies. So, but here, this is the general incidence. But whereas in women with PCOS, they have a higher chance of developing hypertensive disorders. The risk factor is 14% versus 2.5 to 5% in the control group, and hyperinsulinemia is found to be the independent risk factor for pregnancy-induced hypertension. And a recent pilot study also stated that continuous use of metformin may reduce the incidence of pregnancy-induced hypertension. Then what is the role of low-dose aspirin? Yes, low-dose aspirin definitely helps in prevention of preeclampsia. So now beautifully the Gestosis Society of India has given us a scoring. So where they have found out that pregnancy-induced hypertension or polycystic ovarian disease or treatment for fertility or ART are found to increase the Gestosis score, and a person who is having a score of more than 3, they are likely to be benefited when you put the patient on low-dose aspirin. And again, in these patients, it is again able to suppress the growth retardation. Intrauterine growth retardation is also reduced. It reduces the chances of preterm labor, low birth weight, and perinatal mortality. However, benefit needs to be confirmed in PCOS and birth weight. So in general, it is a controversy. What will be whether we will be having a macrosomic baby or a small for gestational age baby. Macrosomic babies are usually found when it is an uncontrolled glycemic status. Small for gestational age babies are found when the patient is already a pre-existing diabetic patient with a vascular involvement. Recent meta-analysis and a large family study showed that there is no difference in birth weight effect between the offspring from a PCOS and a control. Now, coming to the perinatal mortality and morbidity, It can be because of lethal malformation of the fetus. It can be due to shoulder dystonia, the meconium aspiration, and extreme prematurity, and having an APSCO score of less than 7. So, what is the relationship between GDM and fetal anomalies? Do you come across more of fetal anomalies when the mother is found to be GDM? Only pre-gestational patient, diabetic patients, they are at high risk of developing fetal anomalies, or when the GDM occurs very early, that is during the first trimester, the chances are likely to happen. Maternal obesity also increases the risk of gestational diabetes, and it is again an independent risk factor for perinatal complication. Okay, this this is what we have to be very clear. Congenital malformations are likely to happen when the hemoglobin A1C level is found to be higher at first visit. So in patients who are likely to be diabetic or GDM patients, you just estimate the hemoglobin A1C and identify what is the level. And if the level is going to be more than 11 or 12, then her chances of developing congenital malformation is definitely higher and termination is advised. Or if it is going to be a borderline, like say 7 or 9, then they have depend based upon the hemoglobin A1C level, the chances of congenital anomalies slightly increases. So we need to counsel them regarding the increased risk of congenital malformation, and they need to have a earlier pregnancy, early anomaly scan to detect, or even a much earlier, the NT scan will pick up severe lesions like the skeletal dysplasias or even the open neural defects. All those things can be identified in the early stage. So this was again another paper where fetal and neonatal complications, perinatal mortality, macrosomia, shoulder dystocia, birth injuries, and all the complications are found to be higher when the patient has got severe hyperglycemia. Then operative delivery. Operative delivery is usually higher incidence in gestational diabetic patients or in pre-gestational diabetic because of increased maternal age and obesity, and most of them may be treated for infertility, and it can be an macrosomic baby or an IUGR baby. So then coming to metformin and PCOS. What is the role of metformin in PCOS in pregnancy? Do we need to continue metformin? This is $1 million question. And now the current concept is in women with PCOS, continuous use of metformin during pregnancy slightly reduce the rate of miscarriage, gestational diabetes requiring insulin treatment, and fetal growth restriction. There is no congenital anomaly or growth IUD or stillbirth as reported in this study. Again, statistically, there is a significant reduction in the GDM, and there is a reduction in the preeclampsia, and hence metformin is found to be a promising drug in prevention of or reduction of incidence of GDM and preeclampsia in PCOS women. So again, this is also found to reduce the early pregnancy loss. Use of metformin reduces the early pregnancy loss in obese PCOS. So duration of metformin use and medical complications in pregnancy. See, the control with no metformin, group A up to 4 to 16 weeks, group B is up to 32 weeks, and up to delivery they have used, and they have found out that there is no miscarriage rate when they were used up to delivery, and the preterm incidence was found to be very low when they had used it up to term, and live birth rate also 100% when they used up to term. So mean birth weight also was significantly more, normal weight babies they were able to get. So again, hypertension incidence is quite low, and then GDM incidence and GDM on insulin incidence, all those were low when they used the drug metformin continuously up to group C. This is a study from Pakistan who have a similar ethnic thing like similar to India. So this was again the onset of metformin versus placebo. Regarding the onset of labor, birth weight, they were not length, Ponderer index. All these things did not have any significance. Significantly altered p-value was not found out. So then again, no maternal similar thing was obtained in regarding the umbilical artery pH and then weight, etc. So to conclude, metformin in pregnancy, it is safe, no issues so far. Efficacy first trimester miscarriage may be definitely reduced. No consistent benefit on other fetal-maternal outcomes. Continuation beyond first trimester, more data is needed. Then again, there are myoinositol. So still we have a doubt regarding the use of myoinositol, role of myoinositol during pregnancy. We need lot of data. So this is the international evidence-based guidelines in postnatal period. Once when the patient delivers, we have to monitor them with a blood glucose immediately in the postpartum period, whether she's on oral hypoglycemic agents or insulin, and the weight has to be monitored, blood pressure, and then ask her to refrain from smoking, alcohol. Smoking means even that includes passive smoking, and ask her to go for a regular diet and exercise. Sleep pattern and mental, emotional, and sexual health among women with PCOS post-pregnancy has to be assessed. Encourage breastfeeding. Annual GTT by blood pressure monitoring, lipid profile has to be monitored. Risk of developing maternal diabetes has to be discussed. We generally say at the end of 6 weeks, we ask the patient to come back and do a fasting sugar and a oral glucose, that is a 2-hour postprandial. So the same thing has to be repeated every year. So I generally advise my patients, when you celebrate the birthday of your child, you have an annual checkup of getting a fasting and a PP blood sugar, blood pressure monitoring, and lipid profile, weight, BMI, and all the other things, because she has to be monitored every year. And maternal diabetes can happen. We have to stress that, like, her chances of getting diabetes is 40 to 50% at the end of 5 years, and she has to have a careful monitoring and follow up the lifestyle modification, and proper community level physical examination, medical examination is needed for this patient. Postpartum cardiovascular complications, that is what I said, hypertension, obesity, and diabetic patients, they have a higher incidence of cardiovascular complications, and hence they need to have a constant physician advice or a cardiologist advice. Pre-eclampsia and eclampsia and hypertensive cardiac disease, they have a higher chance of developing not only cardiovascular disease, central nervous system stroke, and congestive cardiac failure is found to be higher. And these people, they have a higher chances of developing postpartum depression, and lactation may be suppressed, especially in obese individuals, and proper contraception and family planning should be discussed in the patients. So what is the future risk to the offspring? Risk of PCOS for the female offspring is there. Risk of metabolic disorder for the offspring, metabolic and cardiac complications for the male offspring, and increased risk of autism for the babies born for the diabetic mothers are there. Then again, this is what female offspring, they are having a high level chance of developing PCOS. In utero expression of in utero exposure of hyperandrogenism causes the development of PCOS, and cross-sectional studies shows that PCOS daughters exhibited high LH and testosterone and hyperinsulinemia and ovarian size during puberty. So risk of metabolic disorders are very high in these sibling offsprings of these polycystic ovarian disease patients. And then among the male offspring, obesity, premature balding, increased incidence of type 2 diabetes, dyslipidemia, and cardiovascular disease are there. And hence, genetic counseling, PCOS has got a strong familial clustering, and therefore genetic etiology is suspected. Lack of reliable association between genotype and phenotype raises the possibility of inheritance of PCOS, if any, can be modified by the environmental factors and the lifestyle changes. So the strongest evidence of an association of a single gene with PCOS is the nucleotide repeat microsatellite marker D19S884 within the intron 33 of the fibrillin 3 gene. However, it is not clear whether on how fibrillin 3 contributes to the pathogenesis of PCOS. So genetic research has to be followed up carefully. And then what is the recommendation from the international evidence-based guidelines? So the preconceptionally, as per general population guidelines, plus assessment of impaired OGTT is essential. Lifestyle modification, reduction of loss of 5% loss will help the patient, and pharmacological treatment if the patient is not responding to lifestyle modification, and bariatric surgery is indicated if the BMI is more than 35 or with comorbid conditions, especially in these patients, because bariatric surgery is supposed to reduce the weight dramatically, and the patient can conceive spontaneously or with ART or with ovulation induction. And we need to tell them that they need at least minimum of 1.5 years prior to planning for pregnancy following bariatric surgery. And if the patient conceives, as for the general population, you need to follow the guideline. Consider them as a high risk pregnancy, and then assessment of IgO 75 grams GCT is essential in the first visit as well as before the 20 weeks. And in the postpartum, as I had mentioned earlier, we need to have the patient should be suggested regarding having a 75-gram OGTT and assessment of blood pressure and cardiac evaluation and contraception and family planning. So the key message is PCOS is a disease of variable etiologies and phenotype. Variety of fertility management helps the women to achieve pregnancy. PCOS is definitely associated with pregnancy loss, DDM and preeclampsia. Alterations in birth weight, perinatal mortality, operation delivery remains debated. All these warrants preconceptional and antenatal counseling and stringent surveillance of pregnant women with PCOS. With careful treatment and monitoring of PCOS, women can have successful pregnancy outcome. And always do not forget to watch for the long-term complications for both the mother and the fetus. So it is now I welcome you for the Tamil Nadu Federation State Conference to be held at Trichy between February 9, 10 and 11, 2024. And thanks for the patient listening from the audience side. Thanks, Chitra and Anandi.
That was a very elaborate thing. Again and again stressing that PCO starts at adolescence and ends only at menopause. So you have to keep a clean watch of them, whatever period that you see them in, whether it be adolescent, whether it be pregnancy, or it is beyond that when you see them during the reproductive age group for other problems or nearing menopause. They may come to you with HMB, but still all this requires close attention. That's the information that Ramani had grossly given to each one of you. Thank you, Ramani, for that excellent talk. Thank you.
Thank you.
Sir, do we have any questions from the audience side?
Niravji, any queries is there? You can just post it here actually.
Just a second, sir. So there is no questions as of now, and one comment which I'll share in the chat box.
Okay. We don't see the chat box in our screen.
Ma'am, you can just press Alt-H in your computer. It will be visible to you for the chat box.
Pardon? Alt-H.
Madam, one query is that that 1:5 ratio of PCOs have the chances of developing diabetes. Is this a common in, for all across genders, or only it's in any particular ratio of population?
See, actually, India is now becoming the capital of diabetes, and obesity is an independent risk factor apart from PCOS. See, the Vaijayanti has clearly mentioned that even the lean PCOS have got a higher incidence of glucose intolerance. But the incidence of diabetes is found to be higher in obese individuals. See, but actually the metabolic syndrome is almost the same. So even if the patient is not a PCO, but if she is obese, the chances of developing diabetes is found to be higher.
Thank you, doctor.
Shall we close this session?
Yes, yes.
Thank you so much, madam. On behalf of Emcure, actually, once again, thanking you for this wonderful deliberation of speech. Both the topics were more relevant for our brands of promotions also, and enlightening the session with a great deliberation by both the speakers. Thank you so much once again.
Thank you, Emcure, for supporting us, giving all
Thank
the
you.
technological support. Thank you.
We had around 70 participants, ma'am.
Very good.